Welcome to the deep dive. Today we are undertaking a pretty complex mission, really getting to grips with aiming for mastery of conditions that sit right at the junction of the female urinary and genital tracts.
That's right.
We're talking about two major areas, urinary fistulae, which are often, frankly, devastating outcomes from surgery or childbirth, and stress urinary incontinence, which is much more common but still incredibly complex functionally.
It really is a field that demands precision, and it's vital knowledge for anyone working in pelvic health. The bladder, urethra, uterus, vagina, they're all packed so closely together, and that's not by chance.
Right. There's a deep connection there.
Exactly. It goes right back to their shared embryological development. And this intimate anatomical and functional relationship, well, that's precisely why injuries during gynae operations or obstetric events are unfortunately quite common. We have to start by acknowledging the sheer weight of that first topic. A urinary fistula is often described as one of the most distressing conditions a woman can possibly experience psychologically, socially, physically. It impacts everything.
Absolutely. And we're not just scratching the surface today. Our goal is to dive deep into the technical specs, the detailed classifications, the exact mechanisms of injury, the really definitive diagnostic steps, and crucially, the advanced management strategies for both repair and restoring function. We want to unpack this so thoroughly that, you walk away feeling like you've truly mastered these conditions. So let's start there with the anatomy of failure. Urinary fistulae. Okay, let's pin down the hard definition first. If we're aiming for mastery, we need the precise biological definition of a urinary fistula and why its classification is so fundamental.
Right. So by definition, a urinary fistula is an abnormal epithelialized communication tract. That means it's a channel lined with skin-like cells connecting the genital tract, the vagina or uterus, directly to the urinary tract, so the bladder, ureter, or urethra.
Epithelialized, okay.
Yes. And for the surgeon, the anatomical classification is everything. It's the absolute blueprint. The sources mention Table 31.1 and Figure 31.1 for a very good reason. Knowing the exact anatomical location dictates every single decision that follows.
Every decision.
Pretty much. From choosing the surgical approach, are we going vaginally or abdominally, to the specific repair technique, the potential complications you need to watch out for, and, well, ultimately the patient's prognosis.
So knowing the precise location isn't just helpful, it literally determines the whole surgical journey.
Okay.
Let's break down those primary types based on the structure involved.
Okay. So if the breach involves the bladder, the most common one we see is the vesicovaginal fistula, or VVF. But you can also have vesicocervical bladder to cervix or vesicouterine bladder to uterus communications.
Got it.
Now, if the injury is higher up in those long, narrow tubes carrying urine down from the kidneys, the ureters, we classify it as either a ureterovaginal fistula or, less commonly, a ureteroabdominal fistula.
Okay.
And finally, if the defect is in the tube that exits the body, the urethra, we call that a ureterovaginal fistula. And, connecting this back to the approach at ureterovaginal fistula, for instance, almost always means an abdominal operation, needing access way back into the retroperitoneal space. Whereas many VVFs, especially smaller ones, can often be successfully repaired through a vaginal approach. Big difference.
Now, when we look at the causes, the etiology, there's this really dramatic, almost ethically stark global divide, isn't there? It paints two completely different pictures depending on where in the world you are.
It's a critical point, this epidemiological distinction. In the developing world, particularly in rural areas without easy access to specialized obstetric care, the sources use rural India as an example. The vast majority, maybe up to 90% of bladder fistulae, are obstetric in origin.
90%. Wow.
Yeah. And the main cause is prolonged, neglected, and obstructed labor. The tragic mechanism there is the continuous severe pressure from the fetal head crushing the tissues, the vaginal wall, the bladder wall against the pelvic bone.
Just constant pressure.
Constant, unrelenting pressure. This leads to profound ischemic changes, basically. The blood supply gets cut off, which then causes extensive tissue necrosis, tissue death.
So the tissue actually dies off.
It does. And eventually, that dead tissue sloughs away, leaving a hole, a communication. And often these women are also dealing with dehydration, local infection. It's a truly devastating situation.
So it's crucial to understand it's not usually a sharp cut or a tear in those cases. It's a crushing injury leading to tissue death. A systemic failure from prolonged mechanical stress, the gravity of that is just immense.
Precisely. Now, contrast that awful picture with what we typically see in developed Western countries. Here, the cause is largely flipped. Operative trauma during pelvic surgery is by far the most common cause.
So surgical injury.
Right. It reflects improved obstetric care, certainly, but it also highlights the inherent risks involved in extensive gynecological surgery, things like hysterectomy, whether abdominal or vaginal, complex cancer operations, and ironically, even procedures designed to fix incontinence, like sling operations for SUI.
Let's get really specific on these surgical and obstetric mechanisms. Starting with the obstetric causes beyond just that prolonged labor scenario. Where are the sort of technical danger points?
Well, the vulnerability extends into operative obstetrics, too. Difficult instrumental deliveries,
Yeah.
if high forceps rotation is needed, or really aggressive traction that can directly traumatize the urethra and the bladder neck.
Okay.
And during a seemingly routine cesarean section, the bladder is actually at risk in several ways. The sources really emphasize that the bladder is most vulnerable when it's not completely empty. So careful mobilization, pulling it down off the lower uterine segment before making the main incision is critical.
So emptying the bladder first is key.
Absolutely. Injuries can also happen if that transverse uterine incision extends too far laterally or too far anteriorly, or if the bladder muscle itself gets accidentally caught up in the suture line when closing the uterus, and the risk goes way up for women having repeat C-sections.
Why is that?
Because of scar tissue, you get severe anatomical distortion, dense adhesions sticking the bladder right onto that old scar line, making dissection much harder and riskier.
Okay, that makes sense. Now, the risks shift quite dramatically when we talk about gynecological surgery, especially injuries to the ureters. Why are ureteric injuries considered so serious? And why are so many apparently missed during the initial operation?
They're incredibly serious because they directly compromise kidney function. And the statistic is quite shocking. Only about a third of ureteric injuries are actually spotted intraoperatively during the surgery itself.
Only a third.
Only about a third. The rest are discovered days, weeks, sometimes even months later postoperatively, and sometimes that delay means it's too late to save the affected kidney. Most of these injuries happen during really extensive cancel surgeries, like the radical Wertheim hysterectomy, where the surgeon has to navigate severely distorted anatomy and dissect incredibly close to vital structures like the ureter.
Okay, so even if the surgeon has identified the ureter visually, what are the ways it can still be damaged and lead to a fistula? Apart from rare congenital issues like double ureters, what are the, say, 4 main mechanisms of injury?
Understanding these mechanisms is key to prevention. First, there's direct injury. That's the straightforward cutting, clamping, or accidentally tying off the ureter itself with a suture.
Right, the obvious ones.
Yes. Second, and this is arguably the most insidious cause, especially for delayed fistulas, is devascularization. The pelvic ureter gets its vital blood supply mainly from small vessels coming in from the lateral side, sort of running down from the pelvic brim. If the surgeon strips that blood supply away during dissection, maybe while trying to clear lymph nodes or extensive disease, the ureter becomes ischemic. It loses its blood flow.
So it's not cut directly, but its lifeline is severed. It essentially becomes a ticking time bomb.
Exactly right. Necrosis, tissue death follows days or sometimes weeks later. And when that dead tissue eventually sloughs off, that's when the delayed leak, the ureteric fistula, forms.
Sneaky. What are the other mechanisms?
The third is thermal injury. Unnoticed damage from electrocautery or laser energy used during the procedure. This causes localized tissue death and, again, delayed failure. And finally, you have the inadvertent inclusion of the ureter in a suture line, maybe when closing the vaginal vault or securing a vessel nearby.
So to really master this, we need to know the map of danger zones. Where exactly are the highest risk anatomical spots for ureteric injury during pelvic surgery?
The ureter is vulnerable basically anywhere it crosses or runs close to a major structure that gets clamped or tied off. First, near the infundibulopelvic ligament, where the ovarian vessels are secured during hysterectomy. Second, deep down in the ureteric tunnel, especially during the dissection for a radical hysterectomy.
Yeah.
Third, the zone near the cervix and vaginal vault. This is critical because the ureter passes directly underneath the uterine artery here, the famous water under the bridge anatomy. Clamping that uterine vessel too widely or too aggressively can easily catch or damage the ureter right next to it.
Water under the bridge, classic.
Classic and crucial. Fourth, near its entry point into the bladder itself. Fifth, up near the pelvic rim, particularly if procedures involve tying off the internal iliac artery. And sixth, near the uterosacral ligaments, an area commonly dissected during procedures like a lunate for pain or when closing the vaginal vault.
And I assume certain pre-existing conditions in the patient make all of this even riskier because they mess up the normal anatomy.
That's a critical point, yes. Any condition that distorts the normal retroperitoneal space significantly bumps up the risk. We're talking severe pelvic endometriosis, dense adhesions from previous pelvic inflammatory disease, PID, large fibroids in the cervix or broad ligament, and of course any radical cancer surgery like a Wertheim. If the normal anatomical planes are lost, the ureter is hiding and highly vulnerable. It's often noted the left ureter might be theoretically more vulnerable due to its closer proximity to the cervix, but really individual anatomy and the specific pathology dictate the actual risk. #4. Clinical features and diagnostic pathways.
Okay, let's switch perspective now to the patient who presents with that constant distressing leakage. The immediate clinical challenge is figuring out where it's coming from. How do we differentiate between a VVF, a bladder leak, and a ureteric fistula, just based on symptoms?
This initial clinical differentiation is often the first and sometimes the most definitive clue. The source material summarizes this well in Table 31.2. If a patient has a vesicovaginal fistula, VVF, they'll describe continuous dribbling of urine into the vagina. But the absolute key finding is that they have NO ability to pass urine normally through the urethra. They essentially can't micturate or have anuria in severe cases.
Because the bladder just can't hold urine, it's leaking out constantly.
Exactly. It's lost its function as a reservoir. Now contrast that with a ureteric fistula. Here, the patient also reports continuous dribbling into the vagina, but, and this is crucial, they can still micturate normally through the urethra.
Why is that?
Because it's usually only one ureter that's damaged. The other unaffected kidney is still producing urine, filling the bladder, and allowing for normal voiding via the urethra. So the patient might feel like they only partially empty their bladder because they're losing volume from the damaged side, but they still can void. Missing this distinction is a major pitfall. You could mismanage a serious ureteric leak thinking it's just a bladder issue, leading to delays, possible kidney damage, and unnecessary bladder surgery.
That's a really powerful diagnostic clue right there. What about the less common types like urethrovaginal or vesicouterine?
Right. The urethrovaginal fistula presents differently again. The woman is typically dry and continent when resting, but the leakage only happens when she increases pressure specifically on the urethra, basically, when she actively tries to pass urine. Then there's the rare but very distinctive vesicouterine fistula, often a complication of C-section. This causes something called Youssef syndrome. Here, the patient actually remains continent because the leak is contained within the uterus, but her main complaint is cyclical hematuria, meaning she passes menstrual blood mixed with urine during her period because the blood flows from the uterus back into the bladder.
Cyclical hematuria. Wow, very specific. Okay, this leads us nicely to the definitive bedside test, the methylene blue or triple swab test. Can you walk us through how this relatively simple test uses dye to pinpoint the anatomical defect?
Yeah, it's quite elegant, really. It leverages the anatomy of the lower urinary tract. First, you insert a catheter into the bladder. Then you carefully pack the vagina with 3 sterile swabs. One low down near the introitus, one in the middle of the vagina, and one high up near the cervix or vaginal vault.
3 swabs, got it.
Then you instill a decent amount, say 50 to 100 milliliters of dilute methylene blue dye directly into the bladder through the catheter. You ask the patient to cough or strain, and then you carefully remove the swabs and look at the staining pattern.
Okay, and the pattern tells you the location.
Exactly. If the middle swab is stained blue, that tells you the communication is directly from the bladder. It's a VVF. If only the lowermost swab stains blue, the leak is originating from the urethral issue or maybe a urethrovaginal fistula. And crucially, if all the swabs are wet with clear urine but show absolutely no blue staining, that's basically diagnostic, pathognomonic for ureteric leak. The urine bypassed the bladder entirely, never mixing with the dye.
Brilliant clarity from such a simple test. Now let's think about the clinical course of that delayed ureteric leak, the one caused by devascularization and necrosis. When should a clinician strongly suspect that?
Good question. If a ureter is completely cut during surgery and missed, the patient usually has a really rough, immediate post-op course. Lots of nausea, severe abdominal distension, maybe an ileus, fever, loin pain. That often needs urgent re-exploration. But the delayed leak, the one from necrosis, typically starts about 10 to 14 days, maybe even later, after the initial surgery. The woman will start noticing that constant passive leakage of urine from the vagina, in addition to her normal voiding pattern.
So the key is leakage plus normal voiding starting a week or two post-op.
Exactly. And of course, if Heaven forbid both ureters were accidentally tied off, that's an acute emergency. The patient presents immediately with anuria, no urine output at all, and intense bilateral loin pain. Needs immediate intervention.
Okay. Beyond the swabs and clinical picture, what other investigations are essential for a complete diagnosis and, critically, for planning the surgical repair?
Well, first off, a pre-surgical urine culture is absolutely mandatory to identify and treat any infection. Then we move to imaging. Cystoscopy is vital. It lets us look inside the bladder, visualize the site, the size, maybe even the number of fistula openings. We can also do an indigo carmine test during cystoscopy, inject blue dye intravenously, and watch the ureteric orifices inside the bladder. If one side doesn't spurt blue dye, that tells you the ureter is blocked or damaged.
Okay.
Then, critically, intravenous pyelography, IVP, or a CT urogram nowadays, is essential. This images the entire urinary collecting system from the kidneys down. It will show if there's hydronephrosis, kidney swelling due to blockage, and can often pinpoint the exact site of a ureteric obstruction or leak. And finally, if urine is collected outside the tract forming a pool, ultrasound might reveal a cystic mass, which we call a urinoma.
All right, let's transition to management strategies, starting with VVF. Establish fistulas. The standard advice is to wait before attempting definitive surgical repair. Why the seemingly long 3-month delay? What's the rationale?
Yeah, that 3-month wait can seem frustrating for the patient, but it's really protective for the surgical outcome. When a fistula first forms, the tissues around it are highly inflamed, swollen, often infected, and crucially, they have very poor blood supply because of the initial trauma or ischemia.
So the tissue's just not healthy enough to operate on right away.
Exactly. Surgical success absolutely hinges on operating on healthy, well-vascularized tissue. Waiting those 3 months allows all that acute inflammation to completely subside, gives antibiotics time to clear any local infection, and, most importantly, allows time for vasculogenesis, the regrowth and improvement of the local blood supply to the area. Operating too early on devitalized infected tissue is almost setting yourself up for failure and recurrence.
Makes sense. Is there any exception to that rule?
The main exception is if there's a strong suspicion the fistula might be caused by an underlying malignancy, like cervical cancer eroding into the bladder. In that case, you need an immediate biopsy to rule out cancer before attempting any kind of repair.
Okay, so once the time is right and the tissue is healthy, the vaginal approach is often preferred if possible. There are 2 key techniques mentioned, Latsko and Chasseur-Moore. What's the fundamental difference between them?
They both aim to close the hole, but they use slightly different philosophies. The Latsko procedure is perhaps simpler. It involves circumferentially denuding, basically scraping away the vaginal skin around the fistula opening, and then closing the raw surfaces together in layers. It can be effective, especially for small, high fistulas that occur after hysterectomy. But its main drawback is the risk of scarring that can significantly narrow the upper vagina, sometimes even causing complete closure or atresia.
Okay, so effective but carries a risk of vaginal narrowing. And the Chasseur-Moore technique, that sounds like the more modern standard based on the principles you mentioned.
Yes, the Chasseur-Moore technique is generally the more widely used flap-splitting method today. It involves a much wider, more meticulous dissection to separate the vaginal mucosa completely from the underlying bladder mucosa around the fistula. This careful separation allows the surgeon to adhere to 2 fundamental principles of fistula repair. First, achieving a tension-free closure, meaning the edges of the bladder defect are brought together without any pulling or strain.
Tension-free is key.
Absolutely key. And second, enabling a 2-layer closure where the bladder wall suture line and the vaginal wall suture line are closed separately, and crucially, they do not overlap. They're offset from each other. This non-overlapping configuration significantly minimizes the chance of the fistula recurring through the suture lines.
What if the surrounding tissue is just too scarred or damaged, maybe from previous surgery or radiation? Is simple closure enough then? This is where grafting comes in, right?
Exactly. In difficult cases, think extensive fibrosis, radiation damage, or maybe multiple failed previous repairs. The local tissue health might just be too poor to support healing on its own. In these situations, we need to bring in reinforcement, specifically a well-vascularized tissue layer interposed between the bladder and the vagina. This brings in a fresh blood supply and provides cushioning.
And what kind of grafts are used?
Common options include an omental graft using the fatty apron from the abdomen brought down into the pelvis, or a Martius graft, which uses the bulbocavernosus muscle and its associated fat pad harvested from the labia majora. Sometimes even a gracilis muscle graft from the thigh is used. These grafts act like a biological patch, promoting better healing in compromised areas.
Okay. Now, if the fistula is very large or sits dangerously close to the ureteric orifice, Or if multiple vaginal attempts have already failed, the surgeon might need to go in abdominally. But what if even that fails? The absolute last resort is urinary diversion. Why is that considered such a high-risk option? What are the specific physiological dangers?
Urinary diversion, rerouting the ureters away from the bladder and into a segment of bowel, is truly the last resort. It's reserved for catastrophic situations. Massive tissue loss, severe radiation damage where healing is impossible, or after multiple failed complex repairs. While procedures like implanting the ureters into the sigmoid colon or creating an ileal loop bladder using a segment of small intestine, or even a rectal bladder can restore continence, the long-term dangers are substantial.
What are they?
Well, the bowel segment used isn't designed to store urine. It continues its normal function of absorbing solutes. This constant exposure of the bowel lining to urine leads to a high incidence of ascending infection traveling up to the kidneys. But physiologically, the most serious long-term risk is developing hyperchloremic acidosis.
Hyperchloremic acidosis. Why does that happen?
Because the bowel segment, whether it's ileum or sigmoid colon, keeps doing its job of absorbing ions, but now it's absorbing them from urine. It preferentially absorbs chloride ions, Cl, from the urine, and in exchange secretes bicarbonate, HCO3, into the lumen. This constant loss of bicarbonate buffer from the blood and the increase in plasma chloride levels causes a serious metabolic imbalance, making the blood too acidic. So diversion essentially trades the misery of constant leakage for a lifetime of managing significant risks like kidney infections, electrolyte imbalances, and also the need for regular surveillance for strictures forming where the ureters were implanted.
A really significant trade-off. Okay, let's wrap up VVF management with postoperative care. What's the commitment required from the patient after a successful repair?
The post-op care is quite strict, and patient compliance is crucial. Continuous bladder drainage via an indwelling catheter is essential, usually for 14 to 21 days, to keep the repair site completely dry while it heals. Antibiotics are standard. Absolutely no vaginal exams or speculum use for about 2 months. And specifically, no sexual intercourse for 2 months to allow full healing without disruption.
2 months.
And one really crucial long-term instruction. Any future pregnancy following a successful VVF repair must, absolutely must, be delivered by cesarean section. You cannot risk vaginal delivery potentially re-injuring the repaired area. We also need to counsel patients that sometimes, even after a successful fistula closure, they might develop secondary stress incontinence. This can happen because the scarring makes the urethra a bit rigid or maybe affects the bladder neck angle or simply reduces the functional capacity of the bladder. Hashtag 6, management of ureteric fistula.
Yeah. All right, let's shift focus to managing ureteric fistulas. Here, the primary goal changes slightly, doesn't it? It's not just about closing the hole. It's critically about preserving kidney function. How do you approach the acute management, especially if the diagnosis was delayed?
Yes, kidney salvage is paramount with ureteric injuries. The approach depends heavily on timing and the extent of the injury. If, say, a bilateral ureteric ligation or obstruction is diagnosed very early, maybe within 48 hours of the surgery, the best course is immediate reoperation to remove the ligatures and place stents in the ureters to keep them open.
But what if it's discovered later and the kidney is already backing up?
If the diagnosis is delayed and there's evidence of hydronephrosis, the kidney is swollen and potentially starting to fail due to the blockage, the immediate priority shifts. We need to perform a percutaneous nephrostomy, or PCN. This involves inserting a drainage tube directly through the patient's back into the renal pelvis to drain the urine externally.
So bypassing the blockage entirely.
Exactly. It decompresses the system, saves the kidney function, and buys crucial time, often a couple of months, allowing the inflammation to settle before attempting a definitive non-emergency surgical repair of the ureter itself.
Okay. Now, what if the surgeon actually recognizes the ureter has been cut, transected, during the initial operation? What are the immediate repair options then?
Recognizing it immediately, intraoperatively, offers the best chance for a good outcome. The options depend on the location and extent of the injury. One possibility is a direct ureterorectal anastomosis, basically suturing the cut ends of the ureter back together over a stent. However, this carries a risk of tension and later stricture formation. More commonly, especially if the injury is low down near the bladder, the preferred option is ureteroneocyscectomy.
Which is?
That means reimplanting the cut end of the ureter directly into the bladder wall. Create a new opening.
But what if the ureter is now too short to reach the bladder without stretching it? Tension is bad, right?
Tension is the enemy of ureteric repair. Absolutely. If the ureter can't reach the bladder comfortably, the surgeon needs to bring the bladder closer to the ureter. There are two main techniques for this. One is the psoas hitch. This involves mobilizing the bladder and suturing its dome high up onto the tough tendon of the psoas muscle on the pelvic sidewall. This effectively pulls the bladder upwards and sideways, reducing the distance the ureter needs to span.
Hitching the bladder up, okay. And the other technique?
For slightly larger gaps, the surgeon might perform a Bori flap operation. This is more complex. It involves creating a flap or tube out of the bladder wall itself, swinging it upwards, and tubularizing it to bridge the gap between the shortened ureter and the main body of the bladder. Both are clever ways to overcome that critical problem of a shortened ureter and achieve a tension-free connection.
Very ingenious. Now, if the ureteric injury wasn't caught intraoperatively and is diagnosed later, after the patient has been stabilized with a PCN, how do you pinpoint the exact location of the damage before planning the definitive repair surgery?
Once the patient is stable with the PCN draining the kidney, we need precise localization. This is usually done using retrograde dye injection under fluoroscopy, live X-ray. Dye is injected up the ureter from the bladder end, if possible, or sometimes down through the PCN tube itself. This allows us to visualize exactly where the transection, stricture, or lead is located and assess the length of the gap, which is essential information for planning the complex reimplantation surgery.
Okay, let's bring this fistula section to a close by revisiting prevention. Arguably the most important step. What are the, say, 3 absolute non-negotiable rules of prophylaxis that surgeons must follow during high-risk pelvic surgery to avoid ureteric injury in the first place?
These are fundamental rules every pelvic surgeon must internalize. Rule 1. In any difficult dissection, especially where anatomy might be distorted, you must actively trace the ureter. Start high up at the pelvic brim, where it's usually easier to find, and follow it down towards the bladder before you start clamping or cutting structures near its expected course.
Trace it first.
Trace it first. Rule 2. Learn to identify it visually and by feel. The ureter typically looks pale and glistening, and if you gently stroke it with an instrument, you'll often see its characteristic worm-like peristaltic movement. That confirms it's the ureter.
Look for the wiggle.
Look for the wiggle. And Rule 3, this is absolutely critical for preventing those delayed necrotic fistulas caused by devascularization. Remember where the blood supply comes from. The ureter's primary blood supply in the pelvis comes from small vessels approaching it from the lateral side. Therefore, any necessary dissection around the ureter must always be done on the medial side. Dissecting laterally strips away those vital feeding vessels, leading directly to ischemia, necrosis, and delayed fistula formation. Medial dissection preserves the blood supply.
Okay, let's shift gears now to a much more common, though perhaps anatomically subtler problem. Stress urinary incontinence, or SUI. Before we talk about why it fails, let's establish exactly how continence is normally maintained. What's the physical dynamic at play?
Right. Urinary continence isn't just a passive state, it's an active mechanism. It relies primarily on 2 things: the structural integrity of the internal sphincter located at the bladder neck, and maintaining a high enough urethral closure pressure. Simply put, the pressure inside the urethra has to be consistently higher than the pressure inside the bladder.
Higher pressure in the tube than in the balloon.
Exactly. And that normal closure pressure difference needs to be greater than about 20 centimeters of water pressure. Anatomically, for this to work properly, the internal urethral maze, the opening from the bladder into the urethra, must be positioned high up, supported above the levator ani muscle sling in the pelvis. And equally important is maintaining the urethrovesical angle, the angle between the urethra and the base of the bladder, at normally greater than 100 degrees.
Why is that specific high position and that sharp angle so crucial for the pressure system to work?
Because it ensures equal pressure transmission. When the bladder neck is sitting correctly in its high retropubic position, any sudden increase in abdominal pressure, like when you cough, sneeze, or laugh, gets transmitted simultaneously and, crucially, equally to both the bladder itself and the proximal part of the urethra just below it. This equal pressure rise on both sides maintains that positive closure pressure, keeping the urethra sealed, and the woman stays dry.
Okay, so SUI, which we defined as that involuntary leakage of usually a small amount of urine, specifically during physical stress, coughing, sneezing, without the bladder muscle itself contracting this, is essentially a failure of that precise pressure balance system. How does the pathophysiology explain that failure?
Yes, the failure is almost entirely structural, a mechanical problem. Due to factors we know well, multiple vaginal deliveries causing muscle stretch or nerve damage, trauma to the pudendal nerve, age-related weakening of collagen in tissues, estrogen deficiency during menopause leading to tissue atrophy, the pelvic floor muscles lose their tone, they become atonic, and the supports holding the urethra up weaken.
So the supports give way.
The supports give way. The bladder neck then descends, it drops below the level of the levator Annie sling, and that critical urethrovesical angle is lost, it becomes flattened out. Now, when abdominal pressure suddenly increases, it's transmitted effectively only to the bladder because the urethra is no longer supported in that high pressure zone. The unsupported fallen urethra gets compressed unevenly or not enough, its pressure doesn't rise equally, the bladder pressure overwhelms it, and leakage occurs immediately. This fundamental anatomical failure is precisely why SUI, or genuine stress incontinence, GSI as it's often called, is the only type of incontinence that we can reliably cure with surgery designed to restore that support.
And the common causes you mentioned being multiparous, menopause, obesity, even having had previous VVF repair surgery, they all tie back to that loss of anatomical integrity and support, right?
Exactly. Smoking is another big contributor, likely because it damages collagen and elastin, weakening connective tissues throughout the body, including the pelvic floor supports. Fundamentally, SUI is a mechanical structural problem, and that generally requires a mechanical surgical solution, but only after we've carefully ruled out other types of incontinence. #8. Clinical evaluation and detailed investigations for GSI.
Right. Before we even think about surgery or any intervention, we need a definitive diagnosis, and we need to categorize the severity and type. The sources mention a clinical grading scale first.
Yes, the clinical grading just helps quantify how severe the symptoms are, which can guide initial treatment choices. Grade PUN is the mildest leakage only with severe stress, like a really heavy cough or jumping or running. Grade 2 occurs with more moderate stress, maybe walking fast, climbing stairs, lifting something moderately heavy. And grade 3 is the most severe, where leakage happens with even minimal stress, like simply standing up or changing position.
Okay, grades 3, 3, 3. But you mentioned something even more crucial for deciding on surgery, the surgical classification.
Yes, this is far more important for selecting the right type of operation. There are 3 main surgical types. Type I is where there's loss of that posterior urethrovesical angle alone, but the urethra itself isn't excessively mobile. It's still relatively well supported. Type 2 is the most common type we treat surgically. Here you have both the loss of the angle plus significant urethral hypermobility. The bladder neck and urethra descend noticeably when the patient strains. This is what modern sling procedures primarily target. Type 3 is the most challenging. This involves intrinsic sphincter deficiency, or ISD. In ISD, the urethral sphincter muscle itself is inherently weak or damaged, maybe scarred from previous surgery or radiation. It just doesn't close properly, regardless of its position. Surgical elevation alone might not be enough here, and these patients might need bulking agents or even an artificial sphincter.
Okay, type I, 2, and 3, angle loss, hypermobility, and sphincter deficiency. How do we confirm the diagnosis objectively in the clinic? Let's start with the stress test.
The stress test is simple, but very effective for demonstrating the leak objectively. First, you ask the patient to empty your bladder. Then you instill about 250 milliliters of sterile saline back into the bladder via a catheter to ensure it's reasonably full. The patient then stands or squats over a pre-weighed absorbent pad and is asked to cough forcefully or strain down. You then remove the pad and weigh it again. Objective SUI is confirmed if there's a net weight gain of 2 grams or more, clearly demonstrating involuntary leakage under stress.
2 grams or more, okay. Next up, the Q-tip cotton swab test. This seems to be the classic way to assess that type 2 hypermobility.
It is. It's designed specifically to measure how much the urethra and bladder neck move. You take a sterile cotton swab, lubricate it, and gently insert it just into the urethra until you feel it reach the bladder neck. When the patient is relaxed, the external end of the swab should be roughly parallel to the floor at 0 degrees horizontal. Then you ask the patient to bear down, or valsalva, as if having a bowel movement. A positive test, indicating significant bladder neck descent and hypermobility consistent with type 2 SUI, is defined as the external end of the swab moving upwards by 20 degrees or more from that horizontal starting position.
20 degrees or more?
Yes. And clinically, in patients with significant hypermobility needing surgery, it's common to see angles of 50, 60, even 70 degrees or more. It really shows how much things are dropping.
And then there are Marshall's and Bonney's tests. These seem designed to predict whether surgery will actually help.
Exactly. These are predictive tests. They essentially simulate the effect of a surgical repair that elevates the bladder neck. In Bonney's test, the clinician uses 2 fingers placed in the vagina on either side of the urethra to gently lift the bladder neck area upwards, back towards its normal retropubic position. In Marshall's test, a similar elevation is done using an instrument like an Alice clamp. While the bladder neck is held elevated, the patient is again asked to cough or strain forcefully. If she no longer leaks while the support is applied, that's considered a positive test.
And a positive test means?
A positive test is a very strong prognostic indicator. It suggests that the patient's leakage is primarily due to that anatomical descent, and she's likely to have a favorable outcome from a surgical procedure designed to provide that same kind of support and elevation, like a sling or suspension.
Okay. Now, for the really complex cases, or when the diagnosis isn't clear-cut, we need more advanced testing urodynamics. What can this battery of tests tell us? And what's considered the new gold standard now?
Urodynamics gives us a detailed functional assessment of how the bladder and urethra are working together or not working together. Cystometry is a core part. It measures the pressure inside the bladder as it fills with sterile water or saline, and also measures abdominal pressure simultaneously. This helps assess bladder capacity, normally around 500 to 600 ml, compliance, how stretchy the bladder is, and whether the detrusor muscle contracts inappropriately during filling, which would indicate detrusor instability, not SUI.
Okay.
Uroprofilometry specifically measures the pressure profile along the entire length of the urethra, both at rest and during stress, to assess sphincter function. This used to be considered the gold standard for diagnosing GSI. We also sometimes use micturition cystoarthrography, MCU, which involves filling the bladder with contrast dye and taking X-ray images during voiding and straining to visually demonstrate that loss of the posterior urethrovesical angle.
But there's a newer gold standard.
Yes, the new gold standard is generally considered to be video cystoarthrography, VCU. This combines the pressure measurements of multi-channel urodynamics with simultaneous real-time fluoroscopic X-ray video imaging. It allows the clinician to see exactly what the bladder, neck, and urethra are doing anatomically at the precise moment that pressure changes or leakage occurs during filling, coughing, or voiding. It gives the most complete functional and anatomical picture.
Moving on to management for GSI. It seems crucial that treatment always starts with conservative measures, right? Especially for milder cases or specific patient groups. What are the key non-surgical approaches?
Absolutely. Conservative management should always be the first line, especially for grade 1 or mild grade 2 SUI, or perhaps in postpartum women where things might improve spontaneously, or even for frail elderly women who aren't surgical candidates. The cornerstones are lifestyle changes, definitely weight loss if the patient is overweight, reducing bladder irritants like caffeine, and absolutely smoking cessation.
And the physical therapy aspect.
That's huge. The real cornerstone of conservative treatment is physiotherapy, specifically targeted Kegel pelvic floor exercises. If done correctly and consistently, usually needing a commitment of 4 to 6 months, these exercises can significantly strengthen the muscular support around the urethra. Studies show they can lead to significant improvement or make symptoms tolerable in up to 60% of women with mild SUI.
60% is pretty good for just exercises.
It is, but compliance is key. If those fail or aren't enough, what about medications for SUI? Are there effective drug options? Pharmacological options for pure SUI are a bit limited but can play a role. For postmenopausal women, topical estrogen cream applied vaginally can improve the quality and tone of the urethral and vaginal tissues, which might help slightly with closure pressure. Then there are alpha-adrenergic agonist drugs. These work by stimulating receptors that help constrict the smooth muscle at the bladder, neck, and proximal urethra, increasing outflow resistance. We also sometimes use certain antidepressants off-label because they have side effects that can be beneficial for continence. The SNRI venlafaxine at 75 milligrams daily, and the older tricyclic antidepressant imipramine at 10-20 milligrams twice daily have shown some success, maybe up to 70% improvement in some studies, likely by increasing urethral resistance.
Interesting. And for patients who aren't surgical candidates or need more physical support, are there devices?
Yes, there are intravaginal support devices. Things like the Contiform vaginal cone are essentially celastic devices that the patient inserts themselves. They are held in place by active contraction of the levator antemuscles, acting as both a support and a biofeedback tool to help with pelvic floor muscle training. For the most severe cases, particularly type 3 intrinsic sphincter deficiency or patients with neurological conditions causing sphincter dysfunction, the ultimate mechanical option is the surgically implanted artificial urinary sphincter, AUS. This involves placing an inflatable cuff around the urethra connected to a pump the patient operates. It has a high success rate, around 80%, but it's a major intervention, requires patient dexterity, and carries significant risks like erosion of the cuff into the urethra, infection, and mechanical failure of the device over time. #10. The surgical spectrum for GSI, the 100-plus procedures.
Now, surgery. The source material mentions almost casually that there are over 100 different surgical procedures described for treating SUI. That sheer number suggests that maybe for a long time we didn't fully grasp the core mechanism, or perhaps no single procedure was perfect. What are the universal goals that all successful modern surgeries for SUI aim to achieve?
That's a very astute observation. Yes, the historical proliferation of procedures absolutely reflects a long struggle to find the right balance between providing enough support but avoiding too much tension or obstruction. The goals of successful modern SUI surgery are actually very focused now. First, you want to reposition the proximal urethra back up into that high retropubic position where it benefits from equal pressure transmission. Second, you need to restore or preserve that optimal urethrovesical angle, ideally around 100 degrees or more. Third, you have to ensure the urethra itself remains pliable and compressible, not rigidly fixed. And fourth, you need to do all this without damaging the intrinsic sphincter mechanism itself.
Okay, so position, angle, pliability, and sphincter protection. Let's quickly review the traditional approaches first. These tended to be abdominal operations involving suspension, often with high tension, which apparently led to significant problems and pushed the field towards the modern slings we use today.
That's right. The older traditional operations were primarily retropubic suspension procedures. The Marshall-Marchetti-Krantz (MMK) procedure involved suturing the tissues alongside the bladder neck directly to the periosteum, the tough lining of the pubic symphysis bone. It was done abdominally, but it had relatively low long-term cure rates and a nasty complication of osteitis pubis inflammation of the pubic bone, so it's largely been abandoned.
Okay, MMT is out. What about the birch? That was popular for a long time.
The Birch colpo suspension was definitely a step up and was the gold standard for many years. It also involved an abdominal or retropubic approach. Instead of suturing to the bone, it involved lifting the lateral vaginal fornices, the paravaginal tissues next to the urethra and bladder neck, and suturing them up to the strong Cooper's ligaments, iliopectineal ligaments, on each side of the pelvis. The Birch had a much better success rate, around 85%.
But the source material highlights that even the birch could cause voiding difficulties in up to 25% of patients. That seems like a really high complication rate. Doesn't that alone pretty much justify the shift away from these high-tension suspensions towards the tension-free slings, even though slings involve synthetic mesh?
It absolutely does. That statistic, up to 1 in 4 women developing new problems emptying their bladder after a birch, combined with the known risk of creating new pelvic floor problems like enterocoles or rectocoles, because the suspension altered the pressure dynamics, really highlighted the downsides of high-tension approaches. The birch was essentially pulling things up too tightly in many cases. It was trying to fix a support problem with excessive tension. This realization that maybe less is more, directly led to the revolution of the combined sling operations, embodying the concept of providing a supportive hammock rather than a high-tension suspension.
Okay, the hammock concept. The first attempt mentioned was the Pereira operation, but the real game changers seem to be the TVT and the TOT slings. Can you compare the tension-free vaginal tape, TVT, with the Transobturator tape, TOT? What's the core mechanism and why did TOT emerge as potentially superior, particularly regarding safety?
Right. The fundamental shift with these slings is moving away from tension towards providing support. The TVT uses a narrow strip of non-reactive synthetic mesh, usually Prolene. It's placed vaginally underneath the mid-urethra, but the absolutely crucial point is that it does not actively elevate the urethra like the birch did. It's placed relatively loosely. Instead, it acts as a stable backstop, a platform, or a hammock. When the woman coughs or strains, the intra-abdominal pressure pushes the urethra down against the supportive tape, compressing it and preventing leakage. The tape only provides resistance during stress.
Okay, so it's tension-free support, not elevation.
Yeah.
But the TVT procedure itself, placing the tape, involves passing instruments up through the retropubic space behind the pubic bone, correct?
Yes, that's the key difference in placement technique. The TVT requires the surgeon to pass specialized trocars from the small vaginal incision up behind the pubic bone in the space of retzius, and exit through small skin incisions on the lower abdomen. While the TVT has high success rates, around 88 and 90%, passing instruments blindly through that retropubic space carries specific, albeit low, risks of serious complications, namely bladder perforation, which needs to be checked for with cystoscopy during the procedure, injury to major blood vessels causing retroperitoneal bleeding, and potentially nerve injury.
And it's precisely this potentially hazardous retropubic route that the Transobturator Tape, TOT, was designed to avoid, making it arguably superior from a safety perspective.
Exactly. The TOT procedure maintains the same fundamental principle of providing a tension-free mid-urethral sling, or hammock. The difference is entirely in the anatomical route used to place the tape. With the TOT, The trocar is passed from the vaginal incision outwards through the obturator foramen, the natural opening in the pelvic bone on either side, covered by the obturator membrane and muscles exiting through a small incision in the groin or inner thigh. This route completely avoids the retropubic space,
Bypassing the danger zone.
completely bypassing the danger zone behind the pubic bone. By doing so, the TOT significantly reduces the already low risk of bladder injury, major vascular injury, bowel injury, and osteitis pubis associated with the retropubic passage of the TVT. This improved safety profile has led many surgeons to prefer the TOT approach for primary mid-urethral slings.
Makes sense. Finally, for those milder cases, or maybe type 3 ISD where the sphincter itself is weak, or perhaps for patients who have failed previous sling surgery, there's the option of minimally invasive injections.
Yes, these are periurethral injection therapies. They involve injecting bulk-forming agents directly into the tissues surrounding the proximal urethra just beneath the mucosa. Common agents include cross-linked collagen, like Contagen, though less used now, silicone microparticles, like macroplastic uroplasty, carbon-coated beads, like Durasphere, or polyacrylamide hydrogel, like Bulkamid. The goal here isn't anatomical support like a sling, it's simply to bulk up the urethral walls internally.
Like adding pads.
Exactly, like adding internal cushions. This narrows the urethral lumen and increases the passive closure pressure by external compression. They are generally less effective long-term than slings for significant SUI, but can be a reasonable option for milder cases, for ISD, or for patients who are poor surgical candidates or have had multiple previous failed surgeries. #tag11, urgent continence and detrusor instability, DI.
We absolutely cannot finish this discussion without strongly emphasizing the need to differentiate SUI from the other major type of incontinence, urge incontinence, which is caused by detrusor instability, or DI. Getting this diagnosis wrong is critical, right? Because operating on DI won't help, and just giving medications for SUI won't fix DI. What defines DI clinically?
You've hit the nail on the head. Misdiagnosis here leads to treatment failure. DI is a completely different beast. It's defined as the involuntary loss of urine, often a large amount that happens immediately following a sudden, strong, overwhelming desire to void, known as urgency. It's caused by involuntary contractions of the bladder's detrusor muscle during the filling phase when it should be relaxed. The bladder muscle basically becomes overactive or unstable, contracting when it shouldn't.
So the bladder muscle itself is misbehaving. What drives these involuntary contractions?
The causes are quite diverse. Sometimes it's considered functional or even psychosomatic in origin. Often it's termed detrusor hyperreflexia when it's associated with a known neurological condition like diabetes causing neuropathy, multiple sclerosis, MS, Parkinson's disease, or a spinal cord injury. But in a large percentage of people, especially women over 40, up to 30%, it's idiopathic, meaning we don't know the exact cause. And crucially, we can cause it iatrogenically. DI can develop after SUI surgery in about 1% to 10% of cases, particularly if the bladder neck was elevated too much or the sling was placed too tightly, perhaps irritating the bladder or altering the nerve reflexes. A urinary tract infection can also temporarily cause these symptoms.
What are the cardinal symptoms that really help distinguish DI from the small stress-induced leaks of SUI?
The symptoms are usually quite distinct. The hallmark is that leakage is preceded by that sudden, intense urgency. Patients often report significant urinary frequency, needing to void much more often than usual, say more than 7 or 8 times during the day, and nocturia, waking up more than once per night to urinate. Some may also describe triggers like leakage happening when they hear running water, or when they put the key in the front door, key and lock syndrome, or even involuntary bedwetting, nocturnal enuresis. It's about losing control of the bladder muscle's contractions.
Since this is primarily a muscle function and potentially a nerve signaling issue, the management is mainly medical, isn't it? What's the pharmacological mainstay?
Yes, the cornerstone of DI management is medical therapy, specifically with anticholinergic drugs, also called antimuscarinics. These drugs work by blocking the action of acetylcholine, a neurotransmitter that stimulates detrusor muscle contraction. By blocking these receptors, the drugs help to relax the bladder muscle, increase its capacity, reduce the number of involuntary contractions, and lessen the sensation of urgency.
What are the common examples?
Older drugs like oxybutynin are effective but often have significant side effects. Newer, more selective agents like tolterodine, Detrol, sulfasenacin, Vesicare, and darafenacin and Abelex are generally preferred now because they tend to have a better side effect profile. However, patients still need to be warned about potential anticholinergic side effects like dry mouth, dry eyes, blurred vision, and constipation. Another class, beta-3 adrenergic agonists like mirabegron, ribetriq, offers an alternative mechanism with fewer typical anticholinergic side effects.
We also noted the SNRI antidepressants being mentioned again here.
Yes, interestingly, the SNRI duloxetine, Cymbalta, which we mentioned for its SUI, is also sometimes used for DI or mixed incontinence because it can improve bladder capacity and potentially modulate sensory pathways. However, again, we need to counsel patients about its potential side effects, including the possibility of decreased libido.
Okay, now what if those standard medical treatments fail? What are the really advanced options for resistant detrusor instability?
For patients who don't respond well to anticholinergics or beta-3 agonists or can't tolerate the side effects, we have to escalate therapy. One option is neuromodulation. PTNS, posterior tibial nerve stimulation, is a less invasive form. It involves placing a small needle electrode near the ankle to stimulate the posterior tibial nerve, which indirectly modulates the sacral nerves controlling the bladder. This is typically done in the office for about 30 minutes, weekly initially, then often monthly for maintenance.
And the other major advanced treatment is Botox, right?
Yes, the injection of botulinum toxin A, Botox, directly into the detrusor muscle has become a highly effective treatment for refractory DI.
Can you explain that procedure? Where exactly is it injected? How does it work? And what's that significant short-term trade-off the patient needs to accept?
Sure. The Botox is injected via a cystoscope passed into the bladder. Using a special needle, the surgeon makes multiple small injections, typically 15 to 30 sites, directly into the detrusor muscle wall, spreading the dose throughout the bladder. Botox works by inhibiting the release of acetylcholine right at the neuromuscular junction within the bladder wall. This effectively causes a temporary partial paralysis or weakening of the overactive detrusor
So
muscle.
it calms the muscle down directly.
Exactly. This dramatically increases the bladder's compliance, its ability to store urine at low pressure, and its functional capacity, reducing urgency and incontinence episodes. The therapeutic effect is quite profound for many patients, but it's temporary, typically lasting somewhere between 6 to 12 months, so repeat injections are usually necessary.
And the trade-off.
The major potential downside, especially with the first injection or higher doses, is that the Botox can sometimes work too well, weakening the detrusor so much that the patient temporarily can't empty their bladder effectively. This leads to acute urinary retention. So, a significant percentage of patients, particularly after their first treatment, may need to learn how to perform intermittent self-catheterization for several weeks, maybe up to 6 weeks or occasionally longer, until the bladder function recovers enough for them to void on their own again. This requires significant patient education, motivation, and acceptance before starting treatment.
That self-catheterization requirement really brings up a critical point about balancing cure versus quality of life, which we should definitely return to. But first, if even Botox isn't enough or not suitable, what is the absolute final major surgical intervention for severe capacity issues related to DI?
That would be augmentation cystoplasty. This is a very major reconstructive surgery reserved for highly selected patients with refractory, severe detrusor overactivity, often associated with neurogenic bladder and severely reduced functional bladder capacity. It involves taking a segment of the patient's own bowel, usually about 25 centimeters of the ileum, small intestine, detubularizing it, opening it into a flat patch, and then suturing this patch onto the bladder wall, effectively enlarging the bladder significantly.
So physically making the bladder bigger using bowel.
Yes. It can offer very high cure rates for incontinence, around 95%, by dramatically increasing capacity and lowering pressure. However, it's a big operation with significant lifelong implications. Most patients who undergo augmentation will need to commit to performing lifelong, clean, intermittent self-catheterization because the augmented bladder often doesn't contract effectively enough to empty completely on its own. It also carries long-term risks related to using bowel to store urine, including recurrent urinary tract infections, metabolic disturbances like acidosis, though maybe less common than with diversion, stone formation within the bowel segment, mucus production, and even a small but recognized long-term risk of developing malignancy within the bowel patch itself. So if we try to summarize this journey towards mastery that we've taken, you can see some clear parallels but also critical divergences. For fistulas, we see the etiology shifting obstetric, causes hopefully decreasing globally with better care, but surgical trauma unfortunately remaining a significant issue. For incontinence, the absolute bedrock of management is accurate diagnosis. differentiating the structural failure of SUI, which often needs surgery, from the muscular or neurological dysfunction of DI, which is primarily managed medically, and the evolution in surgery itself, moving from those high-tension suspensions like the Birch to the tension-free support principle of slings like the TOT, really underscores how a better understanding of the underlying mechanics drives more successful and safer interventions.
Yeah, the sheer complexity we've explored today is pretty immense, from the really delicate anatomical knowledge needed to avoid devascularizing a ureter to the subtle but critical differences between all those surgical procedures for incontinence and understanding the pressure dynamics. It really drives home that these systems aren't just separate plumbing. They function as a single, intimately interconnected unit down there.
Absolutely. And that profound complexity, that interplay between structure, function, nerves, and muscles, leads us perhaps to a final provocative thought for you, the listener, to maybe mull over. Given the development of treatments like Botox, which can offer truly dramatic relief from debilitating detrusor instability, but often comes with that significant short-term trade-off of needing self-catheterization, where should we, as clinicians, and where should patients draw the line? How much temporary lifestyle disruption or the need to learn a new skill like CIC is warranted in pursuit of what might be considered a cure, or at least long-term control, for a highly distressing condition? This question, navigating the boundary between pushing the frontiers of advanced intervention and respecting the practicalities and preferences of a patient's long-term life, is arguably one of the most critical clinical decision points in this entire specialized field. And it just highlights again the absolute necessity of thorough, individualized preoperative assessment and counseling for every single patient.
That's a really compelling thought to end on. It reminds us that true mastery in medicine extends far beyond just the technical skills. It is shared decision-making and genuine patient advocacy. Thank you for joining us for this deep dive.